Okay, I think we're going to begin. I want to welcome you to the final workshop in the Dissemination and Implementation Science series. Just a few things. First of all, I want to welcome everyone and thank you very much for attending. Secondly, I'm going to be placing some things in chat. One has to do with the other series that we still have going, especially responsible conduct of research. That is a ongoing series. We have about 2 more left in that workshop series. And then I also want to tell you that I'm going to be putting in the chat at the end, not only the information for the activity you're going to be doing, but also information on the survey you can complete that we would really like you to complete, because we use it to improve our series and we also use it to report to our funding source. And then finally, I want to welcome you all and tell you that, again, we have Dr. Ranjit Singh, Director of the D&I Science Corps, Dr. Bonnie Vest, who is Associate Director of the D&I Science Corps, and Marissa Camacho, who is Research Assistant, Primary Research Institute, Primary Care Research Institute, and she also works very closely with the D&I Corps. And I'm going to turn it over to them with one exception. Please, if you have any questions, please either type them in chat or you can unmute and you can ask the question. They're always willing to answer questions quite organically. Thank you very much, and I'll give it over to our really excellent speakers.
All right, thank you. Hi, everyone. So as Catherine mentioned, today is our final workshop in our first D&I workshop series. And so today we're going to be talking about identifying and using implementation strategies to address barriers and facilitators to implementation. And so as we said, this is the 4th workshop in our series. The series has been recorded, so if you missed any of them, reach out and we can help you get access to those recordings. And if you've made it through to the end with us, thanks for hanging in. So today we're going to talk about some of the methods and processes that we use in implementation science to identify barriers and facilitators to implementation. And then once we know what the barriers and facilitators are, to think about how we can then tailor our use of implementation strategies to those identified barriers to help improve the likelihood of a successful implementation. So when we think about, and as we've talked about in previous workshops, whether or not your implementation succeeds or fails is often a result of a set of complex contextual factors that can either be barriers or facilitators to your implementation. And so as we've talked about in the past few workshops, this could be aspects of the intervention itself. It could be factors related to the context in which you're implementing the intervention, or some combination of the fit or lack thereof between the two, between the intervention and the context. And so when we're thinking about identifying barriers and facilitators, it's important to keep in mind that they're often multi-level. So they're occurring at many different sort of points, system level, setting level, individual level, et cetera. And we'll talk about that a little bit more going forward. Barriers and facilitators can also be different for different groups who are involved in your intervention. So the barriers for a patient to engage in an intervention might be different than for the provider to deliver that same intervention. And these are also sometimes complex factors that are sort of multi-directional. So an identified factor that's influencing your implementation can sometimes be both a barrier or a facilitator, depending on how other factors are at play. And so as a result, thinking about how we identify and address these barriers and facilitators is a complex process, and it requires methods that can sort of handle and work with this complexity and really understand it. So now I'm going to turn it over to Ranjit.
Okay, thank you. So as Bonnie said, trying to handle and digest the complexity of, sorry, I think we need the previous slide, Evan. Part of the complexity is about different levels. Thank you. And as she said, it's multi-level. Barriers and facilitators occur at multiple different levels. So one way just to start understanding those levels is to use an existing framework called the socio-ecological model, for example, that divides these factors into different layers. Now, this model, and there are variations on it, but in general, it's used to understand, for example, determinants of health outcomes. And what it says is that health outcomes are a result of factors at all of these different levels, starting from the individual level at the beginning, in the middle, all the way out to the societal level at the outside. And even though this is not an implementation science model per se, this type of thinking has found its way into implementation science models. And if we look at frameworks or models in implementation science that try to understand barriers and facilitators to implementation outcomes, they tend to look at things at these different models as well. So we can almost think of this social ecological models as a type of implementation framework looking at determinants, looking at barriers and facilitators at a very high level without getting into any detail, right? It shows you the different levels at which these things can occur. So we'll come back to this one at the end in a little activity that we'll do in the groups, which Marissa will lead. But this is a useful structure for thinking about barriers and facilitators. And I think what's good about it also is it's familiar, right? Because it's been used in a lot of other contexts, and many people on the call right now probably have used it or are familiar with it. So it's a good starting point. And you'll also see when we get to looking at other models, you'll see that these levels are built into some of the other more fleshed out implementation models. So let's go to the next slide. So as Bonnie also said, and we've talked about in previous workshops, particularly workshop number 2, one type of framework with implementation science is called the determinant framework, which does exactly what we're trying to do today, which is describes the types of barriers and facilitators that occur that influence implementation outcomes. That's what we're looking at, right? Implementation outcomes. Things that will either make it easier or harder to get these implementation outcomes that we're looking for. And we need to find a way to organize them into a framework so that we can do multiple things by organizing them. One is it helps us to plan our studies to identify factors that we want to look for so we can design our measurement tools around identifying constructs from these frameworks. And by using standard terms and standard constructs, we can also compare results across studies. And so the first step in developing in these frameworks is to have domains. And for example, and there are, if you see in the second bullet, it says acknowledge multiple levels of influence. These are sometimes called domains. And they also seem to correspond, if you look at them, they correspond loosely at least to the layers of the social ecological model as well. So individual is the same as the inner circle. We've got inner and outer referring to the next layers around the circle. So even though the terms are slightly different, they roughly correspond to the same type of thinking. And there are 3 specific determinant frameworks listed on this slide here. CFER, which we're going to go into in more detail today, which definitely explicitly identifies inner and outer settings, which we'll see, as well as individuals. So that correlates more closely to the social ecological model. The theoretical domains framework and Paris also do acknowledge these different spheres of influence, although they're structured differently, but they still kind of have the same concept embedded in them. So let's go to the next slide. So talking about CFA more specifically, you can see here that CFA has 5 domains, and I already alluded to the 3 in the middle, right? Starting from the bottom, the individual. Then next up is the inner setting. So the individuals refers to the individuals who are implementing the new innovation or whatever it is you're trying to implement. the thing, right, as we called it before, the new treatment, the new protocol, whatever it is, the new program. The individuals are implementing it. So usually that might be healthcare workers or public health workers or even patients themselves. But the individuals who the individuals are will depend on what it is you're trying to implement. But generally it's team members in the healthcare system. The inner setting refers to the place in the healthcare system or in the public health system, wherever you are, the specific place where you are actually trying to implement the thing, right? So that might be a hospital or a clinic, or it might be a part of the hospital or a part of the clinic. That's the inner setting. That's this place where the actual rubber is hitting the road. The next layer out is the outer setting. So that is everything else, right? So if you're talking about a small piece of the hospital, then the rest of the hospital is part of that outer setting. If you're dealing with and as is everything else beyond that, right? If you're dealing with the whole hospital or an entire healthcare system where you're actually implementing something across an entire healthcare system, then your outer setting will be all of the things outside of that. Whether it's community, whether it's the healthcare policy environment, whether it's the payment environment, whatever, all of those things that are outside of the inner setting are in the outer setting. And then you can see the other ones are listed there. So I'll mention the innovation one because I'm going to talk more about that on the next slide, but the characteristics of the innovation itself are important. So these 5 domains are like the main headings within CIFAR. Underneath each domain are a set of constructs. Altogether in CIFAR, there's a total of 48 constructs. We'll see on the next slide an example of two of the domains. So on the left side, we've got the innovation domain with 8 constructs underneath it. On the right side, we've got the inner setting domain, which is, again, inner setting, the place where you're doing the implementation. That has several, you can see, domains and subdomains. So let's start with innovation domain. I'll just give you 2 examples. So in the innovation domain, this is the thing we're trying to implement. Characteristics of it that may make it easier or harder to implement. So let's look at A, the innovation source. So this is who developed or is sponsoring or recommending this thing. So that might be, for example, a guideline. If we're trying to implement a guideline, then the guidelines come from some kind of organization like American Academy of XYZ, right? If that's a reputable and credible organization, then it makes it easier to implement. That's intuitive, I think. But if it's not, that makes it harder, right? So that's an example of source. Another example might be complexity. So if I think it's intuitive, if something is easy, if something is simple to do, just take a pill and go to sleep, right? That's the simplest thing. Then that's presumably easier to implement than if the intervention requires you to go somewhere and get an IV placed and then get labs drawn and then get the thing. That's going to be much more that's more complex and therefore harder to implement. So these things, some of these things are very obvious and kind of intuitive. Some are a bit more subtle. But those are examples under innovation. I'll move now to the right side of the screen. We have inner setting. So these are the characteristics of the organization in which you're trying to implement the thing. So this gets a bit more interesting, potentially. So let's look at B, relational connections. So if you have an organization in which, well, any organization or any context in which you're trying to implement something is inherently includes multiple different types of staff, potentially different roles, different infrastructure, and maybe there are different pieces within the organization. So if you're trying to do something like introduce a program for, I don't know, screening for mental health and referring to a counselor and then liaising with the physician to come up with a plan, then that requires relational connections, right? It requires people to be able to communicate with one another, to know one another, to be able to effectively hand off information from one to the other. So in that type of an intervention, the relational connections would be important. In my other example about the intervention is to prescribe a pill and for the patient to take the pill, that might not depend so much on relational connections, right? But in a situation where you need people in a team to coordinate and work together and come up with a plan, then this construct of relational connections might be much more important. And then I'll just mention one other category, which is D, culture, which has 4 subcategories to it. And you can see that there are different dimensions of culture that are identified here that are all important. And so some of them have to do with the inherent equal worth and value of human beings. Well, that sounds very global. That's something we should apply in our lives as well, right? But it turns out that that could be an important construct in implementation of innovations in healthcare, depending what it is, right? You see other examples there. So some have to do with the culture around continual improvement. Well, I think it's intuitive that the culture of an organization can have a major impact on how feasible it is to implement something in that culture. And again, the beauty of these frameworks and this particular example of laying out these individual constructs is it allows us to call them out specifically and study them and then try to intervene to address them. So that's kind of a quick tour of CIFAR, again, with 5 domains, and I just gave you some examples from 2 of the domains. Now I'll hand it back to Bonnie to talk more about how we can use this type of thinking going forward. So thank you.
Yes. And, obviously we're not going to go through all 48 of the CIFAR constructs. I think you would all leave us very quickly if we did that. But at this link, you can go to the website for CIFAR and see all of the different domains and dimensions. But we just wanted to introduce it in a little more detail than we had done previously to help inform what we're going to talk about next. So once you have identified a framework like CIFAR and you've decided that this is a framework that you find useful and that you think you want to use in your study, the next question is, how do we assess? What methods do we use to assess all of these things? So we have all of these domains and constructs within CIFAR that Ranjit just described, but how are we going to measure culture in an organization? And how do we measure relational networks and how people are talking to each other, and how do we assess those things? And so there are a lot of different options for doing that. And a lot of times we're combining these. So, in a lot of implementation science studies, when you're at that phase of identifying barriers and facilitators to implementation, you'll see commonly a lot of different things like observations, interviews being done, focus groups, surveys, maybe some sort of community advisory board structure where they're giving, feedback on a regular basis on the implementation or on the design of the intervention. And so there's lots of different options. And a lot of times you'll see these things in combination with each other as well. So it's not a, choose one. You may decide that culture is best measured through observations, but we can get people's feedback on whether they think the intervention is valid and reliable through a quick survey. So, there might be a different combination depending. And as we talked about before, you can also think about, based on your expertise and knowledge of your intervention and of your settings and of the question you're trying to answer, we don't have to assess all of CIFAR at once. We can also pick and choose certain domains to focus on. And some things to consider around all of that are, what are the aims of your project? How complex is the setting in which you're implementing? So are you piloting your implementation in a single clinic or a single site, or is this a multi-site project across very similar sites? Or is this a multi-site project across all different types of clinics? So you have private practices and academic practices and federally qualified health centers all together. All of those different factors of variability, the more variability we introduce into our implementation, the more complex it becomes, the more we might need to think about our methods a little differently. How many stakeholder groups are there that we need to be involving and getting feedback from? Do we need to be talking to patients and providers? Do we just need to talk to the individuals who are implementing the intervention? All of these sorts of things. And then also thinking about, are there validated measures for what we're assessing? If there are, then we might want to use those and do a survey with these validated measures. But if there aren't, and it's something for which there are no measures, then maybe qualitative methods are more appropriate in that case. So thinking about all of these different factors and then putting together a combination of methods that help get at those questions. And then, of course, very practical considerations around staffing and budget and resources and time to do these, because we know certain methods are much more time and labor intensive than others. So, lots of different options. And we'll talk through an example at the end of this presentation that maybe will make this a little more concrete about how we can do this. And I just also wanted to point out that there are some tools that have been developed, and I think people are continually developing more to assess aspects of CFIR. So, for example, the intervention domain that Ranjit talked about, there are some survey tools that have been developed to try to measure that. So this is an example. This is called the Perceived Characteristics of Intervention Scale. You can see on the left of this table, these are some of the concepts that are in CFIR, right? The complexity of the intervention, like we talked about, how compatible it is with the organization. Relative advantage is a big one. Do people believe that this intervention is more effective or more useful or superior to what they're already doing? And then there's a series of items and questions that correspond to these concepts. And so you may decide that you want to get some feedback using a tool like this on, particular aspects of the project. The folks who developed CFIR have also developed this tool, which they call the Pragmatic Context Assessment Tool. It doesn't measure all of CFIR, but it does elicit some quantitative ratings for 10 of the CFIR constructs. And it just asks people to rate each of these on a 3-point scale. Do they disagree, neutral, or agree? And so if they're disagreeing, then that indicates an item is a barrier. If they agree, that means it's a facilitator. And so you can see here in this table, these are the questions in the tool. So it's a pretty quick, short assessment. And these are the CFIR domains that it maps to. I think we mentioned previously that there are 2 versions of CFIR, the original, which was in 2009, and then an updated version. So this table actually shows in both versions of CFIR which domains these questions correspond to. But this is another quick way that you could get some insight into some of these tools. Or some of these areas and how they may relate or not to an intervention that you're trying to implement. And I do want to mention, just a Google search will also give you some other websites. There are websites out there that have sort of tried to curate and catalog validated tools around these various implementation aspects, either for CFIR specifically or some just for general implementation type outcomes like feasibility, acceptability, readiness to change, these kinds of concepts. So there are tools sort of out there, and we can, talk about those resources if you're interested, but where it can give you a starting place to help find what tools are out there. And so again, it's just a snapshot and an overview of some of the different things that you would consider. And often we're doing qualitative work because we want to get more into the weeds sometimes than we can with a survey. And so maybe we're doing a survey about the intervention quickly, but when we really want to understand how an intervention fits into workflow and process within a setting, then we might need to do something more qualitative like observations or interviews to really understand sort of the complexities of how the intervention is working in that place. The other component to think about as you're sort of designing and a study to understand barriers and facilitators is to think about the timing. when are we assessing these barriers and facilitators? Are we just doing it at the beginning before we even start to implement? We want to understand what the barriers are to prepare us so that we can be successful in our implementation. Are we doing this as we're implementing to kind of understand, what's happening in real time? Are we doing it at the end after we've tried to implement something and we know whether it worked or not, and now we want to talk to people and find out why it worked or why it didn't? So there are lots of different options. And again, sometimes we're doing it at multiple stages of a project and sometimes different approaches at different stages. And there are some of the implementation models we've talked about or mentioned. We didn't go in detail into the example here, the pre-seed, proceed, but that's a model that's used in implementation science, a process model that kind of lays out the steps for assessing contextual factors in the planning process and then also throughout the implementation. So, and so you might want to assess barriers and facilitators over time because the factors that you're identifying ahead of time are sort of an informed guess, but new things may emerge as people actually use the intervention over time. And we also know that the context is always changing. So those inner and outer setting factors that Ranjit talked about are not static. They are changing as well. So we may be in the process of implementing something, and halfway through the study, the insurance policy regulations around coverage change, and that changes how things are going. So, there are always these factors that we need to think about doing when we're doing an implementation study, because they may not be static throughout the entire course of our study. Or the people delivering the intervention change. That's a big one, right? Staff turnover. And so I just want to highlight one method that we have seen in the literature in implementation science for kind of assessing barriers and facilitators multiple times throughout the course of an implementation study to kind of get at this change that's happening. And so this method is called periodic reflections. And it's sort of like a series of mini interviews, but we're not thinking about this as full scale, full-blown qualitative interviews. It's more guided discussion. So the way that they set this up in this initial study where they describe this method is that they would have a structured regular interval discussion with the key members of the implementation team at each site. So depending on the study and the activity and what makes sense, the intervals may change, but it could be monthly or every other month or quarterly based on how the activity is going. And then they had this structured template they were using to guide this discussion so that each time they could have like sort of systematic documentation of what's going on, what they've worked on during that time frame, what challenges and solutions they encountered, what adaptations they made along the way, and just sort of a structured, systematic way to capture all of those evolving contextual factors over the course of an implementation. And they really nicely, with this paper, at the link below, there's a sample template for how they set up their periodic reflections and documented it. And so that's one approach, a more qualitative approach, but without doing, 60 interviews every 3 months or something like that, where you can kind of get some quick ongoing feedback and picture of the different barriers and facilitators that are arising and also how they're being addressed over the course of the study. Okay, so now we have identified, let's say now we know what a lot of the barriers and facilitators are, right? Might be to our implementation, but as G.I. Joe told us, that's only half the battle. So now we need to know, what do we do about these barriers and facilitators? We know that maybe the complexity of this intervention might be a challenge in this setting. And we know that the inner setting factors, the place we're trying to implement this to has a culture that's sort of resistant to change. They like to do things the way they've always been doing them. So what do we do about these barriers now? How do we identify strategies to help address these things so that we can have a successful implementation? Where did my mouse go? There. Okay. So, another framework. We love our frameworks in implementation science. So, the ERIC framework is basically a catalog of implementation strategies. So ERIC stands for the Expert Recommendations for Implementing Change. And here are the citations for the papers for ERIC. And basically, the ERIC framework, these recommendations were developed through a very detailed, like, expert consensus process. So they brought together a bunch of experts in implementation and had them rank different strategies and make recommendations, and kind of did this analysis to come up with this set of strategies for implementation that then provide sort of a menu or catalog that you can choose from as you're designing your implementation to think about what strategies you want to use to help move the implementation along. So like CIFAR, ERIC is complicated. There are 73 discrete implementation strategies that they identified through this consensus process, and they organized them into 9 clusters, which is what this graphic sort of shows. This is from their paper. They did some sort of factor analysis to group the strategies into these different categories. But so we have these big categories of the types of strategies you might use. So they might be financial strategies. They might be supporting the clinicians. They might be adapting your intervention to the context. They might be making changes to the infrastructure. So all of these sort of big buckets. And then within each bucket, there are individual discrete strategies that you can choose. So for example, under the engage consumers bucket, there are several different unique strategies that you might use during your implementation, like just involving patients and consumers in the process of implementation to get their input and buy-in, or prepare them to be active participants. So providing some education and empowerment and engagement. So that is the ERIC strategy of intervention strategies and care that we might think about using for an implementation. So now we need to put those two pieces together. So we have CIFAR, we have all of our barriers and facilitators identified, or at least an idea of what they might be. And we have this toolkit of implementation strategies that we can choose from. How do we sort of connect those dots and say, all right, barrier X, we need solution Y to help address that barrier? Well, there's a solution for that as well. So some folks came up with what they call the CIFAR to ERIC mapping tool. And so you can download this full tool at the link provided here. It's linked directly through the CIFAR website. And what this tool does is help you think about within any particular domain and construct of CIFAR, what are all of the available implementation strategies that might help move the needle in that area. So this is just one example of sort of this mapping. So relative advantage, again, is that idea about whether the intervention is better than what we're already doing. Does it confer an advantage over the usual practice? And if you identify that that's a barrier, that, people don't really see this as any better than what they were doing, so they're not motivated to change, what are some strategies you might need to use during the implementation to help people's perceptions change of the intervention and to see it as more advantageous? So you might have to offer some incentive structures for using the new intervention. You might want to just do some basic education on the intervention. Maybe they don't see it as beneficial because they don't know enough about it. Maybe you need to identify some champions who are really enthusiastic about this intervention, who can help advocate for implementation at their site. So we won't go through all of these, but this tool helps you say, all right, here's an area I've identified as potential barrier. What are some strategies that address that barrier? Okay, so now we're going to make this a little more concrete, hopefully. And I'm going to talk through an example of a study that I was on, which I believe I mentioned previously. This was a poster that we presented at the annual conference on the science of dissemination and implementation. And it was exactly about this issue of sort of identifying barriers and facilitators and then thinking about what strategies we would use to overcome them. So the next several slides are kind of pieces of the poster. I chunked them out into individual slides so that we can talk through. So the Prime Care study was a VA-funded study that was implemented nationwide. And so the study was the Precision Medicine and Mental Health Care study. And the PI was Dave Oslin, who's at the Philadelphia VA. And the context of the study was that this was a randomized control trial examining the effectiveness of a pharmacogenetic test for informing prescribing for treating major depressive disorder. So the idea is that you'd get a cheek swab from your patient. They would send it out for genetic testing. It would analyze their genome as it relates to the metabolism of psychotropic medications. And then the provider would get back a report that sort of divided the available medications into buckets of whether or not they were likely to interact with the patient's genotype. And so it would have like a green bucket of medicines where there's likely to be no interactions, a yellow bucket where there might be some interaction, meaning the patient might experience more side effects, or they might not respond to the typical dose. And then a red bucket of probably should not, think about using a different medication for this patient. And so this testing was rolled out across 22 VA healthcare sites across the country in both primary care and mental health clinics within those VAs. And the providers referred patients to the study, and then that dyad was randomized to receive these testing results to inform their prescribing or to receive them sort of later down the road. So this was a hybrid 2 trial, if we remember back to our discussion of study design. So they were evaluating whether or not this pharmacogenetic testing was effective for improving depression outcomes at the same time that we were doing an implementation study of how this testing was being used in practice. And so that's what we're going to talk about, is the implementation part of that, which is where I was involved. So we did qualitative interviews at the end of the study with the doctors who were using the pharmacogenetic test results. And we interviewed, at the time that we presented this poster, we had interviewed 53 providers. This was kind of a work in progress at the time that we did this poster. We had interviewed 53 providers and across 16 sites, with interview questions around focusing on CFIR, but within CFIR, really focusing on the inner and outer setting aspects of CFIR. And then we did some analysis on that data and used this mapping to CFIR to ERIC to make some recommendations for strategies that could help overcome these factors. So what this ended up looking like, to give you an example, is that, so one of the things that providers kept talking about in treating major depressive disorder in their patients and using this pharmacogenetic test is that veterans are a unique patient population, that the veteran population was very complex, have a lot of sort of trauma and mental health burden, and also have some unique attitudes towards mental health care, and some maybe greater stigma around seeking care for mental health than, a non-veteran population. And so this was sort of the factor that was identified that influenced, how they were treating depression and how they were using this genetic testing in those treatment decisions. So if we think about what that maps to within CFIR, that's in CFIR, that's in the outer setting, and it's the characteristics and the needs of the patients. And so then we use that CFIR to ERIC mapping tool. The strategies then that that might be recommended to help address this factor is to involve the patients. One of the strategies, obtain and use patients' feedback. And again, the one I mentioned previously about preparing patients to be active participants. So maybe we need to do more upfront education and work with the veterans before they sit down with their provider and start talking about this genetic testing and medications for depression. So there are several more examples on these slides, which I know will be sent to you. I'm not gonna go through all of them, but this was the table that we had on the poster. So you can see for each theme, each factor we identified that was influencing pharmacogenetic testing uptake, we then were able to identify some strategies that might help address that factor, and we came up with some examples. So I'll just go through one more. So this is that issue of the organizational culture that we were talking about. Everyone we talked to said that, you know, the VA really has this using quality improvement and evidence-based approaches as sort of part of their organizational mission. There's a strong culture around adopting new practices and new evidence. And so in this case, this was not a barrier to implementation, but a facilitator. And so what strategies could we use to even enhance this further, right? So we might want to be doing tools for quality monitoring of the use of this pharmacogenetic testing, or the ERIC strategy of conducting small cyclical tests of change and implementation. So we might want to be using data to show uptake among providers and kind of giving them that feedback about the use of this test and how it's impacting their patient care. So again, you know, you can look at these slides after and see some of the other examples. Another one I just want to highlight here, formulary restrictions were an issue in some cases because this was a commercially available test. It would sometimes come back with all of these medications that were recommended in the green category that were not on the VA formulary. And so the provider was like, well, I can't use this test result because all the medicines that it says would be a good fit for my patient are not covered and not approved. So that's a big barrier to the fit between the test and the setting and the setting factor about what medications are approved under their coverage. And so what are some strategies we can advocate for to address that, right? There might be issues around changing record systems or changing approval processes for non-formulary medications. There might be some advocacy at the system level that needs to happen about putting some of these medications on the formulary. So thinking about sort of policy and procedure at the bigger level that's influencing the ability to use this, this intervention. Okay, and then just a final note, the other thing to think about is that these, you'll notice if you dive into the CFIR to ERIC mapping tool that the same strategies come up for multiple different constructs. So one implementation strategy could really influence multiple different identified barriers. So the example we gave here, one of the strategies is to promote adaptability and adaptation. And so that could address a few different identified factors that are influencing, right? So like this local distribution of responsibility for mental health care, different VAs have slightly different processes for who is responsible for treating patients with major depressive disorder. Is it primary care and they're doing a lot of the management themselves, or are patients being referred almost immediately after they're identified to specialty mental health? Those different factors might influence how you're adapting the use of this test in that setting. So hopefully that more concrete example we just went through kind of puts a little bit of makes this all a little more clear about how we might kind of put all these pieces together over the course of a study to really systematically identify our barriers and facilitators, and then think about intervention or implementation design strategies that might help to address some of those factors so that we're being successful in our implementation. And now I think we'll turn it over to Marissa, who's going to introduce our discussion. I think, Ranjit and Marissa, we probably just stay in one group again this time and do this discussion as a group rather than breaking out. Do you think?
Yeah, that works.
Okay.
Okay, so Catherine, can you put the Word document for people to download in the chat if possible? But similar to the activity that we did at the last workshop.
Oh, sorry, Marissa. I was just going to say maybe before we jump into the activity, we should just pause and see if anyone has any questions.
Oh, yeah, please.
Yeah.
There are no questions in chat, and the worksheet is in the chats.
Okay.
Perfect.
All right. Thanks.
Okay.
Sorry. Go ahead.
No, you're fine. So similar to last workshop, we're kind of adapted a study that's been published and trying to have you guys think about using different sort of methods and thinking about different levels for this workshop, specifically barriers and facilitators. So we basically are asking everyone to, given the study information below and using the socio-ecological model, we would like to have a discussion about identifying potential barriers and facilitators to the proposed intervention and what approaches you could use to assess the factors at various levels. And again, it's completely okay to stay broad and there's no one right answer to any of these. But I can just quickly review the study information. The following information was adapted from Rodriguez et al. 2023. So the study goals are going to be to identify factors influencing implementation of a multi-component care coordination intervention, nurse coordinators plus a patient registry focused on cancer survivors with multiple comorbidities, and an integrated safety net setting. So the population is going to be pediatric cancer survivors, and the setting is going to be an urban safety net health system serving disproportionately under and uninsured ethnic and racial minorities. And the intervention is going to be the care coordination between oncology and primary care teams through the patient registries and the designated care coordinators, which are going to be the primary care nurses in this case. So for those that aren't familiar, registries allow identification for all patients with specific conditions, including cancer, diabetes, hypertension, other comorbidities. And then the nurse care coordinators are going to manage referrals and connections between specialties and ensure that relevant clinical information to manage a patient's care is available and accessible to all the clinicians at the point of care. So if we could start at the individual level, you can put in the chat or you can speak out if anybody has any specific barriers at the individual level to this intervention. We can go through each level. We'll do the barriers first, and then we can do the facilitators. So barriers for the individual level, if anybody has any thoughts, or we also might need to have you take a couple minutes to digest and look at the scenario, but okay. In the chat, barriers, low health literacy. Yes, especially regarding multiple conditions. Yes, I agree. That would be a big barrier at the individual level. Exactly. Does anybody else have anything? Financial constraints? Yep, I agree. mistrust in the system. Yes, exactly. Okay, so we can move on to the next level for barriers, the interpersonal or relational level. Distance to care, yep. This interpersonal level kind of can focus on like family, friends, peers, coworkers, that can potentially influence the individual's behaviors and health choices. So if that kind of gives a little bit more context to that level, or communication between, yep. Difficulty with communication, yep, exactly. Yep, language barriers or phone service, lack of time and resources, poor communication between teams, yeah, I would say so. Definitely. So we can move on to the next level, which is going to be the community level. Does anybody have any sort of suggestions on potential barriers for that?
Marissa, are we also doing facilitators as well, or only barriers?
I was going to do the barriers at each level and then facilitators at each level.
Okay, right.
Facility readiness, okay. Yeah, I'd say that's a good one. Infrastructure.
Yeah, there's a few more in the chat too.
Okay.
Hours of operation, staffing.
Yeah. Limited staffing, yeah. Okay, great. So then moving on to the societal level, kind of that outside circle that Ranjit and Bonnie were talking about. Does anybody have any potential societal or like policy level barriers potentially? Yep, insurance. It's going to be a big one.
Mm-hmm.
Yep.
Weak
Yep.
national policies.
Yep, weak national policies.
And of course, policies vary by state as well, right? Which makes it interesting.
Yep, definitely. Okay, does anybody, so we can go to facilitators now, unless anyone has anything else to add. So let's talk about facilitators at the individual level. Does anybody have any sort of ideas about facilitators at that personal level?
And in this case, I think the personal level could be the patient, but it could also be the individuals at the clinic that were these care coordinators and the nurses that were asking to do this coordination. Those could be the individuals as well.
Yep, definitely. High motivation to stay healthy. Yep. I agree. That would be a good motivator at the patient level. Does anybody have any suggestion for the nurse care coordinators?
Yep. Yeah. It could be their training, right? It could even be like sort of subtle things at the individual level about whether they think they're already good at coordinating care and understanding their patients' needs. And maybe they don't feel like they need to follow this new registry process because they already think they're, coordinating well. And so they don't think this is necessary. So, it could be those kinds of attitudinal factors as well.
Yeah, and I think work time to use the registry could be a barrier or a facilitator, whether or not they're administrators at the clinics allow them to have dedicated time for this care coordination, or whether they have to try to fit it into their already existing workflows. I think that could be a really good point. So training for the coordinators, again, I think that if the training is perceived to be well and it helps them gain the knowledge of like the potential use of whatever platform the registry's on, or communication workflows, I think that that could be a big facilitator. Effective communication between nurse care coordinators and primary care teams. Yeah, so if they already have really good communication skills, I think that could be a great facilitator. So can we think of any facilitators now at the that, interpersonal level, which is going to have like your individual relationships, families, peers, support teams?
I think one thing we haven't mentioned yet, that these are pediatric cancer survivors and that we're talking about. So, and this is one of those things that could be a barrier or a facilitator, but sort of the relationship within the family too, about what the parents want for the child, and depending how old the child is, what their own sort of goals and wishes are, that sort of interpersonal level of communication and dynamic could be a barrier or a facilitator for different folks.
Yeah, exactly. No, that's a great point. As well as for, we have in the chat for non-English speakers an advocate that can help them navigate communication. I think that that's good. Whether they have, on staff, the nurse coordinators have interpreters that can help with that personal communication between the patients, I think is really important. That could be a huge facilitator. And then prior good relationships between the coordinators and patients. Yeah, if you already have existing relationships with these nurses having within the primary care setting, having good relationships with the primary care doctors of the patients, but then also all their specialists at other offices, I think that that would be a really big facilitator. So let's go to the community or organizational level. So do we have any facilitators at that level?
I think one is that it mentions that this is happening in an integrated safety net system. So they may already have shared medical records or other, communication between specialty and primary care, if they're all within an integrated system that would hopefully facilitate this.
Yeah. Existing standard operating procedures. Yeah, I think so. If there's already sort of referral pathways that exist, that they could easily, thinking about it being a facilitator, they could easily be adapted to the intervention if they already exist. That's a really good point. Anyone else have any thoughts? Okay, we can move on to the societal or policy level task shifting models. Yeah, I agree. Yep, at the organizational level. Yep. So moving on to that societal policy level, can we think of any facilitators that could possibly exist in this situation? Yep. Payment models. Yep. That support care coordination work. Yep. It's a really good point. Yeah. National organizations for cancer survivors that support this work, seamless record transfers. Yeah. I'd say that those are all kind of at that higher level, outside circle.
One other thing we think about sometimes is like quality metrics or other measures that healthcare providers are sort of measured by, from whether it's Medicare or Medicaid or other systems. Those can sometimes, if there are metrics that align with this work, that can help people buy into the need to do these types of activities.
Yeah, definitely. Does anybody else have any thoughts? Okay. So how would you now approach to measuring, possible barriers and facilitators in this situation? And again, you can stay very broad, and there's no one right or wrong answer. I know that Bonnie touched on some methods used in the example that she gave on that specific study that she was involved in, but then also just some general ones earlier in the slides. So if anybody has any thoughts, feel free to shout them out or put them in the chat.
Marissa, do you want to look at that table that you made? Are we going to try to, is that what you're talking about now? Is the table that's underneath this? No.
Yeah, like there's the column for assessing the potential approaches at the different levels.
Yeah.
So we have follow up with parent caregiver interviews. Yep, it's a good idea. Nurse training in or perceived competency in using online records and registries. Yeah, that's a really good one as well. Clinic record reviews. Yeah, that's a good one.
Yeah, record reviews, interviews. We might want to do some, some, again, you could do some surveys at the beginning to see, what experience people have with using registries for care coordination, or what their perspectives are on that, or to, ask the patients about what gaps they see in care, things like that.
Yeah. And then patients utilizing referrals versus no-shows. Yeah, that's good. FGDs.
Is that focus groups? Is that what you mean by that?
I'm not sure. Is that what you mean in the chat? Sorry. Yes, focus groups. Yep.
Yeah.
Yeah. Focus groups with the nurse coordinators, focus groups with parents of the pediatric cancer survivors, focus groups with even the survivors themselves, potentially. So I think
I like the idea in the chat of looking at people who use the services versus those who didn't.
Yep, that's a really good one. Yeah. Yep. Great. Does anybody have any last minute thoughts at all or questions about the activity? Thank you all for participating.
Any other general questions or discussion about the things that we've talked about in today's workshop? Hopefully this has been some helpful information, and again, just a starting place of things to think about, as you're planning an implementation study or an implementation in general, and thinking about all the different ways we can classify and categorize barriers and facilitators, and then how to approach addressing them. But if there's any questions or discussion, we're happy to stay on and take those.